Next up is Steve Murphy. Steve is going to speak on the hipsextant navigating the acetabulum cup placement.
Good afternoon. Thank you again, Seth, for the opportunity to speak. These are my disclosures. One question is, why would we navigate the cup? This lecture is on the same topic as Joe's lecture, but approaches it a little bit differently. Certainly, wear and dislocation are the most common reasons for revision total hip arthroplasty, and cup malposition is directly associated with wear, dislocation, metal hypersensitivity, and pseudotumor. And the article from Mass General that was published in August clearly shows that more than half of their cups are very significantly malpositioned. So we do need to do a better job. But in general, most surgeons don't use navigation for a variety of reasons, but it may be too time-consuming, too expensive, and too disruptive to the procedure to be incorporated easily. So we focused on a fast, simple, and accurate solution for doing this. So this can be done either with CT or with plain X-rays, but it's easier to explain on CT. This is a 3D model establishing an anterior pelvic plane. Then we established a second plane that we calculate relative to that. One is just adjacent to the superior spine. Another is down in the incision on the ischium behind the posterior rim. And then the third is defined by the instrument, and it's essentially equidistant to the first 2 points and on the surface of the bone, which makes it a unique location that we can find with the instrument. Now we have two coordinate systems, the anterior pelvic plane coordinate system and the hipsextant coordinate system. And then once you know in that individual patient how it's going to lie, you can decide where you want the cup to go in a clinical orientation, and the numbers down in the lower left will show you what numbers to adjust the instrument. They're the arm lengths and the two protractors on the top of the instrument that you can adjust on an individual patient. You can adjust those numbers before surgery, or if you decide you can change them intraoperatively. Once you've done that in surgery, you prepare the cup. We use a calibrated drill guide to find the base point down on the ischium, and we put a guide pin there. Then we place the cup through the incision and then slide the navigation instrument over that onto the ischium and lock it down. Next thing is to palpate the superior spine and percutaneously put a trocar through a cannula onto the bone, and we palpate that to make sure we're right at the edge with the trocar falling off and on the superior spine to make sure we're in the right place. Then the next thing we do is put the third leg of the instrument onto the iliac wing, and that docks the instrument. Now we've registered the pelvis in 3 dimensions without having to touch any other anatomy on the other side or around the pubic symphysis area. Once it's docked, we just there's a net resultant vector that points in the orientation that you decided you wanted your cup to go into, and you just line that up by eye. Even medical students can get within 2 degrees, having never done this before. So that shows it from the side. And we have a parallel guide if you really want to tune it very closely with your eye. And this shows it looking straight down from above. So we have the ability to measure cup accuracy with 2D, 3D matching using specialized software that uses the pre-op 3D CT to correct for malposition of plain radiographs, and this has been shown to be extremely accurate. The most accurate way to measure cup position short of getting a post-op CT. And we compared to a control group of 146 CT-based navigations that we had done previously. The results show a number of things. Both are fairly accurate, but the mechanical navigation group is actually more accurate than the traditional CT-based navigation, both for inclination and for anteversion. It was very highly significantly much faster than the traditional navigation. This was just published in September. This is a scatter plot showing plus or minus 10 degrees from the target. The black dots are the mechanical navigation. The open dots are the CT-based navigation. You can see all the black dots are within plus or minus 10 degrees of the goal. That was a group of 70 that I had done. We did another group of 45 cases with 7 different surgeons. Again, all black dots, all plus or minus 10 degrees at the target value. So the next question is, do we have to get a CT? So we started to look at whether or not we could do this on plain radiographs. And we did 3D models on 402 patients with CT, and we also looked at AP and lateral radiographs to see if we could develop a statistical model to be able to predict the 3-dimensional structure of the pelvis based on 2 images. And so then we just used 2 X-rays, an AP that looks like this, where the SI joints and the superior spines are more or less collinear. And on the side view, a standing lateral view where the near hip obliterates the far hip. And these are the results of predicting how the sextant will land based on 2 radiographs versus 3D CT. They're all less than 2 degrees, and the maximum error is 5 degrees. So we have some advantages to using mechanical navigation. It's much faster. It's simpler. There's no line of sight problems. There's no capital equipment issues. We don't have to fix reference frames. And we're able to handle much, much more complex anatomy, which typically fails with CT-based or image-free navigation. So we're working on a mechanical navigation instrument where we can accurately perform component orientation within 3 minutes of OR time, based either on CT or on plain radiographs. And so we're trying to make more progress in a simple, fast, and accurate way of solving one of the biggest problems in hip arthroplasty. Thanks very much.
Steve, thank you very much. That was terrific. Sounds like you should drop a few of these off over at the MGH, huh?